Good morning, everybody. Are we feeling well fed now? Thanks to all you early risers and you punctual people. How does this sound volume-wise? Is it good? Okay. So Phoebe and I thought it might be appropriate to start off with a little bit of a breathing exercise. So just to ground us and center us as we enter this space together. Get ready for a big day of learning. Okay. So if I could have everybody just put down your breakfast for just 1 second and close your eyes and find your pulse either at your wrist or at your throat, your carotid artery. Find it there and just notice it. You're not counting, you're noticing the rate, you're noticing the quality, you're noticing any energetics around it. Okay, once you've got a sense of that, take your left hand and put it over your heart. And take a moment to just tune in to the energetics of the heart space, the electrical field around the heart space. And then put your other hand over your abdomen. We're going to take a big deep breath in for 4 counts together, drawing breath in from the top to the bottom, feeling the left hand rise over your heart, and then your right hand rise over the abdomen. Hold at the bottom of that breath for 4 counts. And then we're going to breathe out together for 8. Pause at the top for 4. And inhale on your own for 4. Pause for 4. And exhale for 8. One more round like that on your own. Now, without opening your eyes, go ahead and touch your pulse again and observe any changes in the quality or the rate or anything different that you notice. Okay, thank you, everybody. Thanks for doing that. And this is Phoebe, who will be doing the last 10 minutes of the presentation and focusing in on some of the metaphysical aspects of the vagus nerve. Okay, so let's get going. I'm going to try to get through the majority of my slides in about 40 minutes. So I'm glad that you all are well-qualified physicians looking at this lecture, because we're going to go kind of fast. Okay. So I really appreciate being welcomed back to NHAND, and also the chance to really geek out on the vagus nerve. There's so many cool things going on in the vagus nerve. So we've got, oops, we let it go for too long. Oopsies, okay. So when it comes to the vagus nerve, we've obviously got, okay, we've got several clinical presentations. We want to go back to that first slide, if that's okay. Yeah. There we go. So we've got several clinical aspects to consider. We've got the autonomic regulation of the cardiovascular system and the gut and the respiratory system and many aspects of the digestive tract. We've got the biochemical regulation of the immune system and the cholinergic signaling that the vagus nerve does via acetylcholine to put reins and immunomodulation on the immune system. We've got the integration of the vagus nerve with the adrenal glands and how the vagus nerve indirectly regulates how much cortisol we secrete. And in that way is tied in pretty impressively with the rest of the endocrine function. And then we've got the metaphysical aspects, as we all just witnessed, where we have this afferent signaling that comes from our environment and depends a lot on what kind of state we're in a mental emotional state, that feeds back to the vagus nerve and tells us how the vagus nerve is going to operate. So our objectives today, well, our good friend Sage is rearranging our slides here. Our objectives today, we're going to identify the clinical presentations of cranial nerve 10 injury that are specific to post-acute symptoms of COVID. But you'll recognize, if you treat any chronic inflammatory disease, which I'm guessing that you all do, you'll recognize echoes of vagus nerve injury in all of your chronic inflammatory patients that have any neuroinflammatory presentation. We're going to review the mechanisms of action of spike protein-mediated damage to cranial nerve 10 and how that goes on to affect the immune system and our autonomic system. We're going to outline treatment strategies based on those mechanisms of action, and I'm going to pause for a minute to say that long COVID, unlike many of the chronic complex infections that we treat, like tick-borne illness, Epstein-Barr virus, things like that, there is a much more direct temporal connection. So most people know when they got long COVID, they got an infection or they got a vaccination and they haven't been the same since. That's unlike many of the tick-borne diseases that we're diagnosing, where it could have happened, you know, you went camping when you were 8 and you haven't been the same since, or something like that, right? But it's a hypothesis. So a lot of times there's that connection that people actually know when they got sick. The other thing is that because COVID happened to the whole entire world all at the same time, conventional doctors, unlike tick-borne illness and unlike Epstein-Barr virus and so many of the other things that we treat, conventional doctors recognize long COVID, and they have been trying to help with it, which is an interesting thing. And so by the time these patients are going to get to you, generally they've already been worked up and assessed by a conventional doctor who's been trying to help with the tools that conventional doctors have access to, which are generally going to be medications. And so one of the things that we're going to look at today is what are the helpful pharmaceutical medications and what are the not so helpful pharmaceutical medications for these patients, because you're going to see them coming in on all kinds of things. We're going to use case studies, hopefully. If we might have to skip over the case studies, we'll see. But we're going to use at least one case study, I hope, to illustrate these strategies. And then Phoebe is going to take the last 10 minutes to explore some metaphysical aspects of the vagus nerve. So these patients, you all have them in your practice, whether you know it or not, with regard, you know, whether you've diagnosed them with long COVID or not. Generally, COVID is the top layer on many, many other layers. So whatever layer you're focusing on. A lot of times there's another layer on top of it that's long COVID in our patient populations. Far and away, the most recognizable piece is going to be their neurologic inflammation, which is going to manifest as anxiety, panic attack disorders, OCD, and this fear. These patients are in chronic sympathetic fight or flight overdrive, and they never get a break from it. And hence, there is a lot of suicidality in this patient population. Much like the tick-borne illness population, there's a lot of suicidality. And so we, you know, often my work with these patients, at least in the initial couple of months, is just keeping them engaged, motivated, giving them jobs to do, to take care of themselves, teaching them self-care techniques so that they have something to keep them occupied as you wait for healing to begin. For the patients that I would diagnose with a vagus nerve injury, their sickness encompasses their entire life. Generally, these are patients that were once upon a time very productive members of society and were young and healthy, and now they're completely debilitated. Much like any chronic inflammatory patient, they're easily depleted, they're intolerant of stimulation, their adrenal glands are generally shot. They have a hard time recovering from things, both on a mental, physical, and emotional aspect. Physical symptoms can run the gamut, but a lot of them revolve around this dysautonomia piece. So you're going to have headaches because of the damage that's been done via the immune system to the back of the head. You're going to have vertigo, arrhythmias, blood pressure fluctuations, dyspnea, and then this really interesting symptom that is the hyper-awareness of the autonomic nervous system function. And so the way that that works is if the vagus nerve is not autonomically regulating our heart rate and our lungs, people know this on some level. They know it intrinsically. And so they feel like they're in charge of having to remember to breathe and remember to regulate the heart rate. There's usually going to be weight loss and malabsorption because of the connections with the vagus nerve and the gut, and this altered pain perception where every stimulus feels a lot bigger than what it is. Often you'll see a personal medical history of triad symptoms revolving around MCAS, POTS, and EDS. And these are the patients that already had Lyme disease in the past or already had whatever in the past. They're the patients that tend to accumulate chronic infections. Sometimes they'll have an autoimmune diagnosis, something like Hashimoto's or something like that. And often, always, there's going to be trauma, right? And COVID was a time when we all kind of went through trauma together, so there's that layer of trauma, but usually there's going to be something in the patient's history that they're going to have to dig out and explore to fully heal. Frequently, because their most forward presentation is going to be the psychiatric presentation, frequently they're going to have some sort of psych med management on board. And so, as it turns out, SSRIs, which are commonly prescribed for these patients, can be very helpful for these patients. And this is in this research, I've really had to check myself and my presuppositions about SSRIs, because in this patient population where there's so much suicidality, you need to keep them alive, at least in the beginning, right? And SSRIs can actually be very helpful for these patients because of the intertwining of serotonin and the vagus nerve, which we'll explore. Let's see. But don't even think about ever giving these patients ADD medications or anything that is even remotely stimulating, because it puts another layer on top of their already dysregulated cardiovascular system. So frequently these patients, because they're tired, will have had some sort of stimulus intervention. That is not a good idea for these patients at all. I like this graphic because it reminds me about the interconnections of tissue vulnerability with the cardiovascular system and with the immune system. So starting, I'm not sure if you guys can see my clicker here, but starting over at the hypermobile EDS, EDS is not just a disease of the joints, right? It's a disease that affects the cardiovascular system, particularly the blood vessels themselves and the integrity of the blood vessels and the lymphatic vessels. And so these patients, because of that easy vulnerability and distension at the level of the endothelium and the blood vessels, they're going to have a difficult time regulating their own blood pressure on demand. So when the body changes position, that involves an autonomic regulation of the blood pressure, right? We have to quickly rise the blood pressure to get blood up to our brain if we're going from a seated or a laying down to a standing position. And if you're moving around all day, you're doing that all day without knowing it. These patients can't do that very well. And so they're going to experience some POTS phenomena, right? They're not going to be able to respond to the changing needs of their blood pressure. And so the heart rate's going to pick up. We're going to have a lot of catecholamine and adrenaline production. And then that's going to go on to stimulate the mast cells, right? Mast cells have receptors for stress hormones. And so mast cells are going to receive this information from the periphery and start getting going with their inflammatory biology. And then what's going to happen? Then we're going to have further tissue destruction, further effects on the endothelium, further effects on the lymphatic system, and this whole cycle just sort of like goes around and around. In the middle, you'll see the overlap of these three conditions, and that pretty much describes long COVID, right there in the middle, right? I'm gonna only mention this slide because I read so much medical research. I am always really excited when I have to come across a good writer. And so if I find the word like foibles in the first sentence of an article, like I'm definitely gonna read that article. I encourage you, if you're into good writing and you're into genetic stuff and you like Tolkien, actually, I really encourage you to read this article. This doctor's mapped out the interconnections between patients with hypermobile EDS and patients with long COVID and their genetic overlap. And this tree that he's built, he refers to it as an Ent, which are the Ents were the Ents were the really large talking trees that helped the hobbits in Lord of the Rings. So read this article if you're into geeky stuff like I am. So common dysautonomic symptoms, we're just going to go through the clinical presentations pretty quickly here and how conventional medicine is going to think about them because this is what patients are likely to be coming in on. The orthostatic intolerance and the cardiovascular dysautonomia go hand in hand, like we just talked about in the last slide. Conventional medicine treatment for both of those things actually is going to be water, lots and lots of salt. These patients can often tolerate up to 10,000 milligrams of additional salt in their diets and a lot of water to round that out. And that's because of the way that COVID affects the ACE2 receptor within the kidney. COVID binds to the ACE2 receptor, and so when we lose kidney function, we lose the ACE2 receptors in the kidneys, we lose the ability to regulate water and salt conservation. And so often we're losing blood volume for these patients. And so the blood volume then, when it's low, goes on to really produce this POTS, cardiovascular dysautonomia type presentation. So lots of salt and lots of water and lots of minerals for these people. Beta blockers are commonly the first intervention that's tried with these patients. For some patients, they work great. For other patients, it just makes them even more tired and need to be horizontal. So it seems like dosing is really important, lower dosing. Often I'm taking these patients off of beta blockers and putting in other regulatory methods because their beta blockers are making them too tired. SSRIs do really shine here, and this is not very naturopathic of me to say, and I'm sorry about that, but we'll go through the mechanisms of action as to why they work so well for these patients. Pupillary dysautonomia, you're going to see in your physical exam, they will not have equal reactivity to light. The sleep dysautonomia is a constant. The sleep dysautonomia is the worst part of this disease presentation. They have these disrupted circadian rhythms. And so a lot of times these patients are on a whole bunch of sleep medications. Benzodiazepines work great for these patients, but what's the problem with benzodiazepines? They're super addictive. And conventional practitioners will get these patients started on benzodiazepines, and then they want to get them off of them because it's a controlled substance. And so these patients don't, adding withdrawal from benzodiazepines to their problem list can be really, really problematic for them. And so I try to avoid the whole benzodiazepine dependence from the get-go, but unfortunately a lot of times they're coming in on them and they're getting good results from them. You just know it's something that's going to have to be dealt with down the road. H1 blockers, particularly the old school ones like hydroxyzine that cross the blood-brain barrier, I really try to push for those types of interventions over the benzodiazepines. Hypnotics, tricyclic antidepressants, sedatives, often these patients are going to have this polypharmacy for sleep that variably has lots of side effects for them. Sometimes it helps them sleep, sometimes it doesn't. The gastrointestinal dysautonomia, you're going to see the gamut of symptoms here. Commonly gastroparesis, alternating constipation and diarrhea, hyper-awareness of everything the gut's doing, and weight loss is a very common symptom in these patients, exacerbated by a lot of them are really intolerant of food or don't even care about food. Conventional treatments here, PPIs are commonly prescribed. PPIs are absolutely the worst thing you can give this patient population because it's going to make their digestion worse, and it's going to contribute to overgrowth of all kinds of fun and exciting things in the small intestine. Frequently, these patients have SIBO, and SIBO treatment does benefit them, but only temporarily, because what's the actual problem? It's that the vagus nerve is not innervating the motility and the function of the gut. So if you don't actually treat the vagus nerve and get that going again, you're just gonna have to keep treating the SIBO over and over again. H2 blockers can be helpful in these patients if they're not already constipated. If it's more of a diarrhea picture, famotidine can actually be very helpful in these patients because famotidine offers a level of regulation for the cardiovascular system as well, because the cardiovascular system has lots of H2 receptors in it. Commonly, you're going to see this thermoregulatory dysautonomia that you'll see in like your MCAS patients. They have a hard time regulating their own body temperature. And a super interesting symptom is about this respiratory dysautonomia. The first and the sickest patient that I ever treated with this type of presentation would say, like, when she was sleeping, she would have to stay awake all night to make sure she was breathing. And that is like a common sentiment that you'll hear from these patients. Like, they don't feel the need to breathe, but they do feel this air hunger. And what's happening there is carbon dioxide levels are rising, and there's metabolic acidosis occurring, but they're not getting the signal to breathe in an autonomic sense because the vagus nerve can't send it because it's too beat up. Conventional treatment for this, these people, if they go and get a sleep study, they'll be diagnosed with central sleep apnea. So commonly they'll have CPAPs that sometimes they benefit from and sometimes they don't. We're going to jump through the mechanisms of action here pretty quickly because I want to be able to have time for all the cool stuff. Direct vagus nerve infection and damage. Postmortem studies in patients that have passed away from COVID confirm that there is lots of COVID RNA in the vagus nerve. And so we know it's part of the way that the early deaths from COVID happened, mostly because of this respiratory dysautonomia. Right, we thought that ARDS was a presentation of inflammation of the lungs in the beginning, but what it actually was the patients were just not getting the signal to breathe, right? And so you put them on a ventilator and hook them up, but eventually you got to take them off of that ventilator, and if you haven't restored vagus nerve function, the patients would pass away. Neuroinflammation mediated by mast cells plays a big role in the damage that happens to the vagus nerve. So the mast cells are the sentinels of the immune system. They're sitting right at the meninges, right at the blood-brain barrier, and they get this message that COVID's coming along. COVID is very inflammatory to the immune system. They're going to get going. It's actually the mast cells that do the majority of the damage at the blood-brain barrier to the vagus nerve. And that's variable depending on how mast cell active that patient is when they get COVID, right? So that doesn't depend on the viral load. That just really depends on the patient's individual immune system. Depending on the viral load, we're going to get variable affects on the cholinergic signaling from the vagus nerve and the production of ACH. There's proof in laboratory studies that there is autoimmune response where the patient will make antibodies to their own nicotinic acetylcholine receptors and muscarinic acetylcholine receptors. So you're getting also variably autoimmune destruction of the receptors. And then this thing about the respiratory rate not jiving with elevated CO2. So mast cell stabilizers are helpful here because one of the ways that you have to sort of start putting out the fire, right, the slow burn of the cytokine storm. Bioflavonoids, which are abundant they're super abundant in our herbs and things, and we'll have a slide about that. Cromolyn sodium and ketotifen are commonly used here for these patients, and H1 and H2 blockers. Low-dose naltrexone is something that's really helpful here as a brain immunomodulatory and also a promoter of serotonin. It's one of the reasons that patients with long COVID do so well on low-dose naltrexone. Cortisol supports neural anti-inflammatories like botanicals, like L-theanine, but also progesterone and pregnenolone, possibly testosterone for both women and men. And then, I know this slide's showing up a little weird here. The antivirals, like this is, in my opinion, like Paxlovid doesn't really work all that well in the acute presentation. It's got a lot of side effects associated with it. I think our herbs really shine in the acute presentation. And then in the longer term presentations, like long COVID, we're often worried about the inflammatory process itself, and viruses become less of a concern. But ivermectin can be a bridge here, which we'll talk about in our slide a little bit later. There also is this problem with spike proteins and what they bind to. So spike proteins can accidentally bind to an acetylcholine receptor. That is how the vagus nerve sends its signals, is through acetylcholine. And so that's a big problem. Then we get antagonism at the acetylcholine receptor, and vagus nerve can't transmit its signals. So we lose our autonomic regulation that way, but we also lose this sort of layer of immunomodulation that the vagus nerve offers over the immune system. All the immune cells express receptors for acetylcholine, and it's an immunomodulatory input that it mediates. And then because COVID likes to bind at the ACE2 receptor, we're going to have ACE2 receptor dysfunction, and the ACE2 receptor is responsible for all of the autonomic regulation of the cardiovascular system, the gut, et cetera, et cetera. This is why nicotine is helpful for these patients. Nicotine patches, because the acetylcholine receptor that we're trying to affect is a nicotinic acetylcholine receptor. If you put nicotine into these patients, it will boot the spike protein off of the acetylcholine receptor. That variably works for people. People that are nicotine naive and very overstimulated won't be able to tolerate this therapy. It'll be too much for them. People that have been smokers previously and are kind of on the tired side, those are good patients. That's a good match for the nicotine patch. And sometimes that can be a game changer. Varenicline, you'll variably see this is a quitting smoking drug that is also used in this patient population in conventional medicine. And then ivermectin and anything that supports cortisol is going to discourage binding. I'm going to summarize this slide because there's a lot in here in this graphic and the next slide, but basically if you're going to read one article, other than the end article, if you're going to read one article, read this one. This article, it's beautifully written, and it beautifully demonstrates the vagus nerve and how damaged the vagus nerve is essentially to blame for all aspects of long COVID. And it thoroughly explores the adrenal connections, the connections with cortisol, and cortisol acting as an immunomodulating force. Beautifully explores the effects of acetylcholine and how it's an inhibitory force, or an immunomodulating force, I should say, to the peripheral immune system. And then it also explores vagus nerve and regulation of the autonomic cardiovascular system. Read this article. It's an excellent, excellent article. And this just goes through everything that's illustrated in that last slide that we looked at. Mitochondrial dysfunction is a really important point about these patients, and often this is where you have to start. So a lot of these patients are very, very, very tired, right? Their mitochondria are just kaput, because they've been recruited to participate in the COVID response, so they've been trying to manufacture reactive oxygen species to help out with our immune system, and that's going to really beat up the tissue around the mitochondria and the mitochondria themselves. Also, COVID and other viruses, their drive is to get to mitochondrially dense tissues. That's why they love the brain so much. They really want to harness that power of the mitochondria. And so when we have mitochondrial invasion by COVID and mitochondrial affects of COVID, we're going to have disrupted ATP synthase, we're going to have disrupted electron transport chain, and we're not going to get energy production at the cellular level. And then there's also a feed-forward thing that happens with mitochondrial genesis and acetylcholine. The acetylcholine is necessary to manufacture mitochondria. The mitochondria help the cells produce acetylcholine, and that whole relationship can go off kilter. So therapies to consider here, these are regardless of how reactive my patients are when they're coming in, these are patients like, I'm allergic to everything, don't even give me anything because I'm going to react to it, right? They all need mitochondrial supports, and generally they can tolerate them. NAD, or sometimes you have to go with just a low dose niacinamide, non-flushing, because they'll get freaked out about the flushing reaction. The glutathione, ALA, CoQ10, PQQ, generally these things are tolerable for most people in low enough dosing, and they start to like jumpstart the mitochondria again. Methylene blue can really shine here. One note about methylene blue is that it will have serotonergic interactions with SSRIs and 5-HTP and LDN, anything else that you're using to promote serotonin. So just watch out for overstimulation and serotonin sickness. Rapamycin, I hope we'll have time to talk about. That is a really cool repurposed therapy that's being used in clinical studies for long COVID. And then photobiomodulation. That is a really beautiful therapy for the mitochondria. I have a cold laser in my clinic that I use on virtually all of my long COVID patients to just jumpstart blood flow and mitochondrial function. Really, really helpful for the long COVID people. This is also where if you use ozone or hyperbaric oxygen, those things are really helpful for the mitochondria, getting them going. So our targets for our long COVID patients, like we made mention of, we really want to engage with the cranial nerve 10. We want to teach them, like we just did in the beginning of our lecture, we want to teach them how to self-regulate. And there's endless amounts of excellent things that these patients can be taught to do, and it helps them with their focus, and it helps them feel like they're doing something to recover. We want to stabilize mast cells like we talked about, and we want to get nerve repair mitochondrial supports. You all have this slide you can read through. Those are just bullet points for therapeutic ideas. This is a bunch of studies that I culled and put together on the effects without even using anything, internal, just using, paced breathing and heart rate variability and biofeedback, and how that in and of itself can be just the healing process for some of these patients. Cold exposure therapy is a really interesting one. If you're interested, I put the PubMed reference there. Cold exposure therapy engages the vagus nerve. Don't do that with people that are really, really depleted. It won't work. They won't be able to recover. Do it with the people that are sort of overstimulated. It works a lot better for them. I put this slide in because when you start looking up and researching long COVID and therapies, this is what you're going to see over and over and over again come up in the literature, transauricular vagus nerve stimulation. You can have patients order a fancy pants, bougie device on the internet. 10? 30, thank you. Yes, okay. Or you can have them, if they're low income, you can get a TENS unit and hook an ear clip up to it, put it right on the tragus. There's a branch of the vagus nerve that goes through the tragus, and then you can attach it also to the concha, and you'll be able to affect the vagus nerve that way. I will say that most of these patients have a really hard time doing this on a regular basis, and for it to do anything, it needs to be done twice a day for like 20 minutes each time. But for patients that are willing to do it, this therapy can be really excellent. And again, it gives them something to do. I put the most common settings for the human studies in there. Mast cell stabilizers really run the gamut. You guys all know about flavonoids and using those, things like luteolin and quercetin as mast cell stabilizers. I'm sorry, the slides got a little compressed here. L-theanine is a beautiful one for this population. Virtually everybody can tolerate it. People that are slightly less tolerant of things, you start low and work it up, but L-theanine is a beautiful mast cell stabilizer for the brain. It really helps to calm these patients down. Pharmaceutical mast cell stabilizers really take some practice to get used to using, and that's because you have to titrate them from low to high. One reason for that is because let's not forget, histamine is a neurotransmitter. It's a monoamine neurotransmitter, like adrenaline and like dopamine, and like serotonin. And so for a brain that is used to having a lot of histamine around, what's going to happen if you start rapidly decreasing that histamine, they're going to get even more tired than they are already. And so the fatiguing side effects of the pharmaceutical mast cell stabilizers, you really got to watch out for. The other thing is that when patients have a ton of histamine floating around, they're not going to have very many histamine receptors upregulated, right? And so if you rapidly drop histamine levels, what's going to happen? All of the histamine receptors are going to get upregulated. And so temporarily, at least, that patient is going to be more sensitive to a smaller pool of histamine, right? And so this is why you have to feed them in a little tiny bit at a time, watching for oversedation. This is particularly true of ketotifen. Ketotifen can be super sedative. It's great for patients that are really overstimulated and just need to calm down and sleep, right? And then you transition them off of it as they start to heal and as they start to regulate themselves. Cromwell sodium is an interesting one because it particularly pertains to the gut. So this one tends to be more helpful when people are presenting with more gut symptoms. Cromwell sodium is a natural, though it's pharmaceutical, it's derived from Amyvisnaga, which is a Ayurvedic herb, and it's a bioflavonoid, and it's generally covered by insurance, and this is a really good one to use. It's less sedative because it's not systemic. It's mostly working in the gut. Generally, we dose it with food because the food will be better tolerated with cromwell sodium. Low-dose naltrexone is worth a try here as a mast cell stabilizer if there's no other polypharmacy that's contraindicated. And sometimes it's really helpful for the histamine-dominant population. I love this slide. I'll let you guys look at it on your own, but these are basically botanicals like passiflora and astragalus and humulus and camellia that are both mast cell stabilizers because they contain high concentration of bioflavonoids, but they're also, have affinity for the nervous system. So these are really beautiful, beautiful herbs. Use them. Love lion's mane in this population. It has this neuroregenerative property, and it allows for neuroplasticity and brain regrowth, brain cell regrowth, and very, very helpful. Caution in your patients that are really reactive to mold and fungal things. They might not be tolerant, they might have an allergic interaction with it, but for all other people, lion's mane is a great one. You dose it at night, then it has time to be involved in like the reparative processes that are going on. These patients will also have variably explored other neuroplasticity-inducing things like psilocybin, ketamine. These can be great therapies for these patients because of the neuroplasticity effects, but make sure that they're done in a supervised setting always with the prep and then the ceremony and then the integration afterwards, right, by a knowledgeable practitioner. Also, patients that have better interoception, they really respond better to these, but sometimes it can be a way of teaching interoception as well and establishing those connections. So on to serotonin. This is another really super interesting article that tells us about the afferent effects of serotonin produced at the gut level by our gut microbiota with short-chain fatty acids. Right? So this really highlights the gut-brain connection, its role in neural inflammation and lack of serotonin, particularly depression. But that is all mediated through the vagus nerve. So I never understood why SSRIs were used for anti-anxiety medications. I think of serotonin as an upper. When I started researching these connections, it all of a sudden clicked. Okay, so we have more serotonin production at the gut level when we're using an SSRI or when we're using 5-HTP or a botanical that promotes serotonin. And then that afferent signals are going to be transmitted up to the vagus nerve, and the vagus nerve is going to know that everything's okay because we're getting nice, healthy production of neurotransmitters, of serotonin in particular, at the gut level. So all of a sudden it made sense. But you don't have to use an SSRI for that. You can get the same effect. SSRIs are just what conventional doctors use, so that's what you're gonna see coming in. If you have extra time, read this article. It's a really cool article. Serotonin supportive therapies that are natural, you guys all know these, 5-HTP, low-dose naltrexone, sort of borderline natural. SAMe is peripherally supportive. Titrate low to high in that one, so patients can get used to the neurochemistry shift. But SAMe is also an excellent strategy for patients that you need to decrease the histamine levels, but you know it's gonna make them tired. You can put in SAMe at the same time so that their neurochemistry gradually shifts over to a healthier, more functional balance. Rather than running all on histamine, now it can run a little bit on dopamine and adrenaline a little bit more, like SAMe promotes. Saffron and St. John's wort, I'm sure there are others. Those are just the two that I know. I've included some studies on SSRIs that highlight these points. And then, so other than the autonomic nervous system signaling, tryptophan metabolism also has this immunomodulatory effect. And this is again why SSRIs and other serotonin-promoting therapies work so well in these patients, is that if you're engaging neurotransmitter production to shift towards serotonin, then you're bypassing what's called the kynurenine pathway that is really active in metabolic inflammation. And so there is this drive to produce NAD via the kynurenine pathway in acute inflammation. And it leads to a whole bunch of toxic metabolites that are then gonna also have effects on the brain. So depriving that pathway of tryptophan and shunting the tryptophan towards serotonin, as it turns out, is both a good strategy for the nervous system regulation, autonomic nervous system regulation, but also to as an immunomodulatory strategy, and less toxic metabolites getting built up. So the neurologic nutrients, most of you are going to be familiar with these. We're going to see phosphocholine in our P5P, methylcobalamin, 5-HTP, MAG3 and 8. I prefer MAG3 and 8 in these patients. Taurine, glycine. Hormonal and adrenal therapies, I've talked about, if you've ever seen me lecture before, I talk about these things a lot. In the mast cell population, pregnenolone, progesterone, neural anti-inflammatory is very helpful in these patients. It allows the inflammation to calm down enough so that they can get out of fight or flight mode, but also helps rebuild the brain tissue. Customized HRT can be really helpful in these patients. Hydrocort and physiologic range. So if your patient is very, very depleted in an adrenal sense, which a lot of these patients are, one strategy is hydrocortisone, but it's in physiologic range. And so what that means is under 30 milligrams per day in divided doses. Within that range, you're not getting the immunosuppressive effects. You're really thinking about hydrocortisone as a cortisol analog, and you're using it in the sense that you would use like thyroid hormone to treat a depleted thyroid patient, right? And so you keep them on it long enough that their adrenal function and its regulatory ability on the blood pressure can engage again, get enough resources, and then you start to transition them over to other things like adrenal adaptogens. Glycyrrhizin is really helpful for this patient population because it can mimic aldosterone and help repair some of that damage that's been done to the ACE2 receptors and its regulation. We made reference to the mitochondrial supports before. Those are awesome. Get them into your patients. They're really necessary. Rapamycin is kind of a cool one. It's repurposed immunosuppressive medication, but the way that it works is in long COVID and how it's being studied is in a low dose pathway that inhibits, low dose methodology that inhibits what's called the mTOR pathway. So the mTOR pathway regulates cell metabolism. When things are good, the mTOR pathway will tell the cell to make more mitochondria, build more, have more anabolic sorts of things going on, build more proteins, make more stuff. It's a good time out there. When things are going off kilter, right, when the immune system is under duress, mTOR is going to get the signal to start increasing autophagy and mitophagy because we've got infected cells and we need to start this programmed cell death so that we don't have infected cells hanging around. COVID hijacks this pathway. And so COVID likes to hijack this pathway for its own viral replication. And so what we have then, if COVID's hijacked this pathway, is we're not getting autophagy, we're not getting mitophagy. These infected cells are just hanging around, perpetuating the viral load and exhausting the immune system. And so if you can inhibit COVID from doing that, then we don't have any of those side effects, right? We get decreased viral replication because COVID can't hijack our mTOR pathway. We are able to clear infected cells and infected mitochondria so that the new tissue can be built. So this is most helpful for patients with a high viral load. These are the studies, if you want to take a look at them. The dosing protocol is 1 to 6 milligrams once a week. And you have to monitor the patient. I have not used this yet, but there are particular biomarkers that you monitor for immunosuppression. Those are a summary of the studies. Oops. Other antivirals, acute versus chronic, we made reference to, like, the time for antivirals, high-dose antivirals, is in the acute stages of the infection, so you can get the viral load down. But that said, like, the most common strategy in conventional medicine is Paxlovid, and Paxlovid doesn't, like, I don't know about you guys, I don't think it works all that well. I can't prescribe it in Maine, but generally the botanicals work much, much better because you're getting also an immunomodulatory effect from the botanicals, which you're not getting from Paxlovid. And so Paxlovid works great in your patients that are older and you're worried about their immune system and their viral load. Otherwise, it's in the younger, healthier patients, they're going to get long COVID anyway. You're worried about the inflammation and you're worried about the tissue damage that's being done. So that's the time to, like, get the immune system under control. The ivermectin controversy, much like the SSRI controversy, like, it's all a matter of opinions, right? So ivermectin sort of got, unfortunately, caught up in this thing of, like, if you use ivermectin, or if you think about ivermectin, or if you talk about ivermectin, then obviously you're like a Maha person and you love Trump, right? That's not the case, right? And so we really try to, like, abstract our own. I really have had to check myself as I've learned all of this stuff because, obviously, nobody wants to be that. And so we, when you start digging around in the research for ivermectin, it is clearly professional suicide to even think about studying it. So there's all of these excellent in vitro studies on ivermectin. It just hasn't been studied in patient populations. So anyway, ivermectin is a great antiviral, but it's also immunomodulatory. And so if you've kept up with Dr. Anderson's work on long COVID, he uses a 0.2 to 0.4 milligram per kilogram dose of ivermectin. This gets compounded. It's given all at once in one dose at night because it has interplay with the GABA receptor, so it can have a sedative effect. This is a great one for persisters of viral infection. It really helps. It does really, really help. It will get patients cooking. You'll get some die-off effects when you first introduce it. 15? Great. Okay. I might have to skip my case studies, but that's okay. That's all right. Well, if you guys are around for the rest of the weekend, I will be around for the rest of the weekend. I am happy to talk about them. Maybe I'll do one case study? Yeah, okay. I'm going to skip these. You guys can read them yourself. I'm going to talk about this one because it's a really interesting one and it highlights the overlap of clinical presentations. So this patient was a PT assistant, 49 years old. Tons of neurological stuff going on that was debilitating, musculoskeletal pain, diffuse migratory joint pain, occipital headache daily, all kinds of GI stuff, no appetite, losing tons of weight, and then this cardiovascular dysautonomia that would keep her mostly in a laying down state for the day, not really able to challenge gravity too terribly much. She's completely disabled. So she went from, like, a very productive member of the workforce to completely disabled almost overnight. History of her illness. She initially presented with her first round of symptoms in 2015. That was probably when she got some sort of tick-borne illness, right-sided body weakness, some neurological stuff. She paid a lot of money and jumped through a lot of hoops to get this diagnosis of functional neurological disorder by Boston Neurology Group. Super helpful, but they stabilized her on duloxetine, gabapentin, and tramadol, and she was well enough, and this patient is super highly motivated, that she went back to, was able to get back to work. She was well enough to get back to work. May of 2023, she had a meniscus repair that she just never recovered from, and probably she had a COVID infection in there. And so she had this prolonged inflammation, poor healing, and development of the current presenting complaints. 2023, her PCP tested her for Lyme. She had one band positive in the Western blot, which if you look at Western blots, you'll know the 41 KDA band is positive on like everybody. But she got started on doxycycline, no improvement. And then she transitioned, she hooked up with a functional Lyme practitioner who diagnosed her clinically with Babesia and started on a Babesia protocol because she's presenting very much like a Babesia patient, and probably there's a layer there. So I started working her adrenal function up right away. And this was when I was using a urinary testing method. She had like literally no hormones, no cortisol, no DHEA, no estrogen, no progesterone. She was like, she had already gone completely through menopause. She was 49. She also had a positive ANA, and but had not been diagnosed with anything that was like something rheumatology would recognize as anything. She had low white blood cell function, red blood cells, mean corpuscular hemoglobin, elevated CO2. Why? Because of the respiratory dysautonomia, right? She's not getting the signal to breathe, particularly at night, and low blood cell distribution rates. So lots of adrenal insufficiency and dysautonomia. Her functional Lyme practitioner put her on a Babesia protocol for weeks and weeks and weeks and weeks and weeks. And I had not diagnosed her as I was just trying to help out. I had not diagnosed her as a long COVID patient yet. So we put her, she had a PCR stool analysis. It was ridden with parasites. I started treating her for those. I started her on HRT, and I started treating her sinuses to see if her vestibular symptoms would get better. She got worse and worse and worse throughout all of this, and she was even more debilitated than before. One thing that's interesting about COVID is that unlike Babesia and unlike tick-borne illness in general, if you're seeking short-term disability, as this patient was, you can qualify for it with long COVID. Long COVID is a recognizable diagnosis that will qualify patients for short-term disability. So mostly because we need to get her short-term disability, we decided to diagnose her with long COVID. And then I was like, wait a minute, if we're diagnosing her with that, maybe we should actually treat her for it. So we moved into a long COVID support. We got her on low-dose hydrocort. She was intolerant of HRT. Many of your unregulated autoimmune patients will be intolerant of estrogen. Why? Because the estrogen will feed the autoimmune process. That's variable. Sometimes you don't see it, but a lot of times you do. We started her on low-dose naltrexone. She was already on Plaquenil from her Babesia protocol, and we started her on liposomal glutathione, NAD. We titrated her up to 3 milligrams of ketotifen at bedtime. It got her sleeping. And we started a brain support formula, and if you want to know what this formula is, come talk to me afterwards. Choline, phosphatidylserine, and lion's mane. Started her on SAMe and methyl B vitamins and a low-dose nicotine patch, 7 milligrams daily. She tolerated that like a champ, and it got her like right up. Volume expansion. She was like not a water drinker, so we had to teach her to drink water and electrolytes and et cetera, et cetera. She started exercising in a recumbent position and sleeping sitting up, which is a really great ways to expand the blood volume. And so she started getting better, she then went back into, she recognized she couldn't be a PT assistant anymore because of the physicality, but she changed careers. She went through a medical assistant training program and got back to work. And last time I talked to her, she was back to work 30 hours a week, caring for her 18-month-old grandson on her day off, and she was like really, really, really super stoked about life. Her persistent symptoms, lots of sleep symptoms still, and she's all done with ketotifen. Most patients will take themselves off of ketotifen because it is so sedative, and so mostly that's because she took herself off ketotifen. But she also didn't tell me that she stopped sleeping after she started titrating up her SAMe, so we just had to correct that. She still is having nausea with sometimes dry heaving, specifically at this point in the morning before the gut has turned on for the day, basically. Migratory muscle pain, metabolic changes. She was having weight gain, which was good, but she was also having some constipation. So we've got a current management support in place, and this patient, because she's so motivated, will gradually get better, and she's gonna do just fine. But she hasn't processed her trauma yet. She is a very, very, very religious patient, And that is excellent, it's great, it provides her motivation and inspiration, but it also means that she refuses to talk about her sexual abuse as a child, and that is still stored in there. And she also refuses to talk about her very unhappy marriage. So somehow or other, we have to start to get her to process that trauma for, for her actual full healing. Otherwise, she's gonna do fine, but that's a big piece of things, right? And it always is in the vagus nerve population. So I think what I'm gonna do is invite Phoebe back up and have her do her thing, and then we might have like a couple of minutes for questions if we have time. Thank you all for listening, so nice.
Thank you so much. Let me know if you can hear me. It's good? Okay. So before I begin, can everybody close their eyes again? We're gonna do the 4-4-8 breaths that Corrie taught us one more time. So with the hand on the heart and the hand on the belly, breathe in for 4 seconds. Fill up the diaphragm and belly. Hold for 4 seconds. And out for 8. Again, at your own pace. In for 4. Hold for 4. And out for 8. One more time. Hello, my name is Phoebe. I am a Colby College senior. Oh, there's more. There we go. You're good. I am a Colby College senior who's mentee to the amazing Dr. Corrie in Maine. I study neuroscience, ancient civilization, and dance, and that is my cat. I'll be continuing our discussion of long COVID by focusing more on the nervous system's role, rounding out our holistic look at treating this illness. Long COVID is fundamentally a nervous system imbalance. Someone initially contracts the virus, then their vagus nerve injury sustains their imbalance for longer than normal. As we have seen, they likely even developed new or worsened sensitivities and symptoms. Vagus nerve injuries impair anti-inflammatory pathways, leading to inflammation, dysautonomia, and neuropsychiatric symptoms. So as a show of hands, how many of you have ever seen any of your patients' pain, fatigue, or symptoms shift the moment their mind felt safe? Again, how many of you have ever seen any of your patients' pain, fatigue, or symptoms shift the moment their mind felt safe? And then I'll have you look around. Keep your hands up. Wow, so their minds, their perceptions influence their body's functions. I'll get into this more, but this is the vagus nerve's regulatory effects in action. But the vagus nerve does not heal solely when we understand it. It heals when a person experiences sensations of safety and embodied presence, which activate powerful neuroimmune and cellular repair processes, demonstrating how the nervous system is the foundation of healing. I invite us to bring our attention to the quote on the screen as well. A new paradigm is needed to explain long COVID. We suggest it is time to break taboos based on a dualistic understanding of physical versus mental illness and bring in existing knowledge about functional somatic symptoms to provide improved explanations and treatments. Today, I will talk about how your body remembers stress, even if you don't, nervous system intervention research for long COVID, how nervous system programs teach what the body already knows, and implications for clinical practice. This was me over a year ago with CFS, mold illness, IBS, SIBO, gastroparesis, an inability to digest food without pain, superior mesenteric artery syndrome, pelvic floor muscular dysfunction, hypothyroidism, hypothalamic amenorrhea, OCD, ARFID, brain fog, insomnia, chronic anxiety, PTSD, basically a storm of dysautonomia. Those of us with experiences of chronic illness know that it often feels like our body has betrayed us. But what if it's the opposite? What if symptoms are our body's memories of the ways it has learned to keep us safe? What if mind and body mechanisms are not separate, and chronic symptoms are actually signals for us to address core wounds? I remember going from practitioner to practitioner, while the root and reasons for my chronic bodily imbalances were never prioritized. At Colby, I'm taking a course on ancient medicine. We learned that medicine used to be tied to how humans conceived of existence and cosmology. In ancient Egypt, an ailment that showed up in the body revealed an ailment to one's sense of self, their community, and their relationships needing to be healed. With the support of therapies, powerful herbs, and rituals, that healing revealed an acknowledgement of the body's interconnection with internal and external systems, and trusted nature's laws of innate healing capability. So what if healing chronic illness isn't something novel we have to acquire, but something ancient we already carry in our bodies? Before I ascend, though, let's see if modern science agrees with this. Well, the polyvagal theory says that we are biologically hardwired for survival through our autonomic nervous system and vagus nerve. Implicit memory lives in the brain's amygdala, insula, and autonomic nervous system. These memories send efferent signals to the skin, digestive tract, lungs, heart, spleen, liver, and kidneys, and brain through the vagus nerve, which bidirectionally communicates between the body and brain, shaping how we predict threat and safety. Through one's lifespan, experiences are synaptically programmed through unconscious encoding of reactions to stimuli. As Corrie mentioned, heart rate variability is the window into the vagus nerve's regulatory effectiveness. High HRV indicates resilience, recovery, adaptability, and a high stress tolerance, while low HRV indicates limited stress tolerance and a poor sympathetic recovery. Acute stress can be useful for survival, but chronic stress sensitizes our nervous system, leading to central sensitization, dysautonomia, high environmental and emotional trigger sensitivity, or vagus nerve injury and dysregulation. Chronic symptoms common with persistent stress include fatigue, sleep disorders, autoimmune disorders, cognitive problems, neuropsychiatric conditions, IBS, anxiety, depression, addictions, and compulsions. So what does this tell us? That the body remembers stress. Sustained stress is encoded across neural circuits as habitual associations or patterns of neural activity in immune cells, endocrine rhythms, epigenetics, and even muscle tension, reinforced throughout the lifespan. But what is behind all neural pattern formation is neuroplasticity. This is the nervous system's lifelong potential for novel synaptic connections and learning. So if the body implicitly learned chronic threat through memory, it can also establish new neural pathways that reinforce safety. Neurons that fire together wire together. And we're actually hardwired for nervous system regulation. It's a survival coping mechanism in itself. When a person finds grounding in things like comedic levity or simple deep breaths, dopaminergic reward circuitry and positive experiences will motivate play, expression, and connection. This releases neurochemicals like oxytocin and BDNF, a marker for neuroplasticity. When we experience a felt sense in our body of harmony with our environments through practices that increase body awareness and presence, interoceptive signals from the heart, gut, and breath increase and promote neuroimmune regulation. Therefore, joyful, grounding behavior is not frivolous, it's reparative biology. When nervous system interventions are practiced by those with long COVID over 3 months to rewire neuroimmune patterns, we see significant reductions in chronic fatigue, pain, dyspnea, and brain fog with psychophysiologic symptom relief therapy. We also see significant increases in well-being and energy across several chronic illnesses listed, as well as decreases in long COVID fatigue and overall symptom severity with an amygdala and insula focused retraining. We also see qualitative reports of enhanced breathing ease, facial mobility, nervous system regulation, and decreased tachycardia with a vagus stimulating auditory therapy. All of these studies will be linked on this slide for further reading with some more supportive literature as well. So when we put all this together, we find that structured nervous system programs work because they harness neuroplasticity, amplifying innate reparative regulation tools, built-in exercises of what feels good as unique people. So healers can provide their own nervous system plans tailored to the people they treat, including the tools such as these structured evidence-based programs. There are also monitoring and biofeedback options for HRV, for patient symptoms, and wearable regulation devices. And we also have these innate tools that I like to separate into self-regulation and co-regulation. Self-regulation can be breath and simple safety cues, humming, movement that feels good, expressive dance, yoga, joyful activities, regular pleasurable visualizations, restorative sleep and routine, interoceptive practices. And because we're social animals, co-regulation can be all of those practices, but with other people, such as collective movement, like contemporary dance, with children, animals, pets, nature, touch, and sound, rhythm, and music. Somatic exercises from the literature typically will first notice the dysregulation with awareness, then slowly integrate a regulatory technique, then establish a new neural pattern of okayness and harmony, and promote long-term repetition of this practice. When the body and mind symptoms are viewed as signals from an interconnected system, attempting to bring us back to homeostasis, healing capacity expands as the nervous system can start to surrender into a restorative, reparative state with cumulative practice. This practice is not a quick fix, and it's extremely hard. It also differs from popular fear-based worldviews within Western medicine today. However, I'm hopeful that we can find how the beautifully intricate explanations that modern cellular biomedicine offer us explain embodied information that we already know. So, why do nervous system interventions for chronic illness matter? While addressing nervous system dysregulation is often central to chronic illness recovery, nervous system-focused interventions rewire survival responses in dysautonomia, relieve chronic symptom severity and increase overall well-being, enhance complementary naturopathic treatments by putting the body in a receptive state to absorb nutrients and remedies via the vagus nerve, and need to be customized as people differ in nervous system sensitivity, genetic factors, emotional and environmental triggers, baseline nervous system damage, and comorbidities. Nervous system interventions also address root wounds, reducing the risk of over-medicalization and more nervous system trauma. For example, many patients spend time, energy, and money on several practitioners' treatments, while in chronically ill states, they experience even more trauma when they're chasing down their symptoms and panicking to fix themselves, while ignoring their screaming limbic and neuroimmune symptoms. Nervous system interventions reduce this risk by rejecting fear-motivated medicine. A body that feels chronically unsafe and fears itself, its own body, or its external world cannot be expected to heal. To start implementing nervous system work, we need to change our relationship to stress and how it is communicated. The nervous system's role can be reframed as the thing that keeps us alive, meaning to naturally find joy and safety, things that regulate us, while also protecting us from harm by forming autonomic, often dysregulating habits and patterns. So it's simultaneously a maladaptive and adaptive system. This is what makes us human, and nothing needs to be fixed. Health is not the absence of stress or symptoms. I still ebb and flow with stress and gut sensitivities. Health is dynamic. It's about maintaining balance, and it's about our symbiotic role within our environments. So to recap, nervous system interventions for long COVID help to teach that healing is not foreign or external. External tools support innate reparative processes. Our task as healers is to collaborate and remind people what it means to trust their felt bodily sensations that alert us how to practice bringing our bodies back to the present moment. This shifts our understanding of chronic illness from one of fear to one of trust. Healing becomes not a fight against nature, but a remembrance that we are nature, designed by the same universal intelligence that biologically, cosmically, brings all atoms and ecosystems back to equilibrium. And here is a ton more literature about nervous system regulation for you. Thank you for listening, and a ginormous thank you to Corrie for letting me speak.
We only have about 2 minutes for questions, and then Dr. Marinaro will take other questions outside of here. Does anyone have any questions?
Corrie, you want to come up here for the microphone?
Hi, I just want to say thank you for this lecture. It was really helpful and very informational. You spoke about the shunting from tryptophan towards serotonin to avoid those like toxic metabolites. I didn't quite catch like what helps that happen.
Anything that promotes serotonin production. So in conventional medicine, generally you'll see the SSRIs used, but you can accomplish the 5-HTP also bypasses the kynurenine pathway, and then your botanicals. It just is like how severe the symptom presentation is, what tool you're going to choose. I can't prescribe SSRIs, and I probably wouldn't. It's not really my role. It's not what I'm trained in. But often patients are going to be coming in on SSRIs, and where I used to try to get people off of them, now for the long COVID, population, I keep them on for at least while they're healing.
You had said that exercising in a recumbent position and sleeping, sitting up helped with something. What did it help?
Sorry, that was a blood volume expansion. And so the exercising in a recumbent position is commonly a part of PT and OT for these patients. If you can get your heart close to your head while you're working or while you're working out, there's less gravity to challenge, right? And so you'll have better success, less exertional dyspnea, and less exertional, post-exertional fatigue. If they monitor their HRV prior to exercising, like if the HRV is low for that day, not a good exercise day. If it's higher, it's gonna be better. But always for these patients, particularly with the dysautonomia symptoms, the exercise starts with things like floor Pilates and your rowers and your recumbent bikes and things like that. The sleeping, sitting up, I have to remind myself what the mechanism of action is for that. I knew it once upon a time, but I can get, who was that asked that question? I can get that reference for you. I promise. Yeah.
I have 2 questions. One is referencing what you were just talking about HRV monitoring.
Yeah.
What do you use? And the second is you mentioned something about LDN and serotonin, and I'm not familiar with that mechanism.
Yeah, so I'm sorry, first question was HRV? What do you use? Yeah, so patients will use variable devices. I mean, there's all kinds of devices out there that can monitor their HRV, but usually I have them wear it at night and then get an average HRV overnight in the morning and have them base what they're going to do for the day on their HRV. So if it's like a low HRV day, then they're not going to be capable of very much. Higher HRV means that's a day they can get more stuff done. These are patients that really have to be careful of depleting all of their resources, right? And HRV is a good way so that they're not like surprised by that. And I'm sorry, LDN, thank you. LDN promotes an upregulation of serotonin. I don't know the mechanism of action off the top of my head, but that is one of the ways that it works, and it's often why people will be in a better mood when they're on LDN. Go ahead.
Does that mean that we need to be cautious with it with methylene blue?
Yes, definitely. Anything that, even with like 5-HTP, SSRIs, but a lot of patients can handle those combinations. It just depends on how depleted they are. If they're already overstimulated, they're going to be much, much, much more prone to that polypharmacy, even if it's not actually pharmaceuticals, interacting together and overstimulating them further. But you'll usually see some sort of gut symptoms showing up with serotonin syndrome. Right? That's usually your clue.
I'm afraid that's all the time we have. Thank you so much, Dr. Marinaro. She'll take some questions outside of the lecture hall.
Definitely. I will.
Thank you.
Thank you guys for listening.